It sits below the breastbone and bores through to your back. You lean forward over your knees, the only posture that helps. Eating provokes it, so you eat less and lose weight. 3 admissions this year, each ending the same. Fluids, nothing by mouth, an opioid pump, discharge. Then one night, the lipase comes back normal while you grip the rail of the bed, and someone writes the words drug-seeking in a chart you will never read. My name is Gurpreet Padda of the Padda Institute Center for Interventional Pain Management. What is failing you is one false assumption, that pancreatic pain tracks pancreatic inflammation. It does not. The gland can burn itself out, fibrose, calcify, go quiet on every study you own, while the pain continues, because it has relocated into the nervous system. So when the enzymes look normal, the chart stops asking why you hurt and asks what you want. That is how a nerve problem becomes a character problem, and how the visit ends the same way every time. There is nothing else we can offer. Repeated inflammation does 2 things. The first is structural. Fibrosis replaces working parenchyma, the duct scars and narrows, pressure builds behind it. The second is neural. Sensory nerves inside the gland enlarge, immune cells infiltrate the nerve sheath, axons sprout into inflamed tissue. The nerve becomes an independent generator, while cord and brain raise the gain on everything arriving. The 2017 International Consensus Guidelines from Drews and colleagues in pancreatology say it plainly. Pain here relates to inflammation, to local complications, and to neurogenic mechanisms with corresponding changes in the nervous system. Most patients who reach me have been treated for exactly one of the 3. Pancreatic nociception does not travel primarily with the vagus. The vagus carries other traffic from this gland. The pain fibers run with sympathetic afferents into the celiac plexus, a dense retroperitoneal network around the aorta at the 12th thoracic and 1st lumbar level, then back along the greater, lesser, and least splanchnic nerves to the thoracic dorsal root ganglia. Before anyone advances a needle towards your aorta, the differential has to be finished. Abdominal wall nerve entrapment is caught in 10 seconds by tensing the abdominal wall. If the tenderness worsens, the source is the wall, not the viscera. That sign points, it does not prove, but a plexus block does nothing for it. Strictly postprandial pain with food avoidance raises mesenteric ischemia. Peptic disease, biliary obstruction, and malignancy must be excluded, and opioid-induced hyperalgesia, because sometimes the treatment has become the disease. The first step is not a procedure. The guidelines place Plexus interventions after CT, not instead of V, alcohol and tobacco cessation, enzyme therapy, stepwise analgesia, and where indicated, decompression of an obstructed duct. They also say something pain clinics rarely read aloud. Surgery should be considered early, after no more than 5 endoscopic interventions. If you have a dilated duct and a surgical option, that conversation belongs before mine, not after it. Abstinence from alcohol and tobacco is what those guidelines put first and the step with the most to give. No trial has raced it against a needle, so I will not pretend one has. It is the one intervention I cannot perform for you and the one most likely to change where you stand in 5 years. Then enzyme replacement dosed adequately taken with food, not an hour later. The guidelines say enzymes may be helpful, and I will use their word, may. They reliably treat the maldigestion and weight loss. Their effect on pain is inconsistent across the trials. Only with refractory pain does the plexus become the target. You lie prone, and under live fluoroscopy, I identify the 12th thoracic and 1st lumbar bodies, walk a needle off the lateral margin on each side, and advance to the target. Nothing therapeutic is injected until contrast confirms spread, hugging the aorta on both projections, with no vascular uptake. Then local anesthetic, usually with a corticosteroid. Some centers do this block under CT, trading live imaging for soft tissue detail. Gastroenterology reaches this plexus from the front through the stomach wall under endoscopic ultrasound. Same target, different door. Now, the numbers. In 2025, Machado and colleagues pooled 11 studies and 729 patients in pancreatology, all given endoscopic ultrasound-guided celiac plexus block. Overall efficacy, 53%. Mean relief, 81 days, 57% improved at 8 weeks, 19 at 12, 3 at 26. The authors concluded that a sham-controlled trial is still needed to establish efficacy. This is a window, not a repair, and those figures belong to the endoscopic technique. I will not quote them as though they describe the block I perform. In pancreatic cancer, the procedure is different. Alcohol neurolysis, which destroys the plexus rather than interrupting it. There, the 2011 Cochrane review by Arcidiacono and colleagues found 0.4 of a point of difference on a 10-point scale, but significantly lower opioid use. Risks belong before consent. After a steroid block, expect transient diarrhea, a drop in blood pressure on standing, and a short flare of pain before relief. Adverse events ran 8% in the pooled series. The neurolysis numbers are a different and heavier set, and I will not blur them together. Eisenberg's 1995 meta-analysis in anesthesia and analgesia pooled 1,145 cancer patients, given neurolytic block, local pain in 96%, diarrhea in 44%, hypotension in 38%, severe complications in 2%. The route carries hazards of its own because the target sits against the aorta, which is what the contrast run is for. Intravascular injection and local anesthetic toxicity, retroperitoneal bleeding, injury to a kidney or vessel, pneumothorax, uncommon but possible, infection. If you take a blood thinner, we plan around it before the date is set, not on the table. Davies, in a 1993 survey of 2,730 neurolytic blocks in England and Wales, found 4 permanent paraplegias, 1 per 683. Those are neurolysis figures in cancer patients from the 1990s. They do not describe the steroid block, and I will not let you walk away thinking they do. That number is small. It is not 0. A word on the metabolic protocols elsewhere in this series. Here I am, more restrictive, not less. A high-fat ketogenic approach is a poor fit for a gland that can no longer digest fat. It buys steatorrhea, not relief. Pro-resolving mediators and near-infrared light are adjunctive and untested here. There is no controlled human outcome data. What matters nutritionally is dull and specific. Enzymes dosed correctly. Fat-soluble vitamins checked. Calories enough to stop the weight loss. I will not dress a hypothesis up as standard of care. What I am about to describe is a picture assembled from many patients with this condition, not one person's chart. An adult with calcific chronic pancreatitis on imaging, 6 years of pain, 4 admissions in 18 months, an opioid regimen tripled without a good day. The first 8 weeks held no procedure. Enzyme dosing was wrong, half the needed dose, taken after meals. We corrected it, and the maldigestion and weight loss improved. How much of the pain change belonged to the enzymes, I cannot tell you. Tobacco was the hard part. 2 relapses before it held. The first fluoroscopic block produced 2 days of worse pain, then relief that was real and incomplete, enough to finish a meal, sleep flat, and start tapering. It held into the 3rd month. I want to be careful with that number. In the pooled endoscopic data, only 1 in 5 is still better at 12 weeks, and nobody has measured the fluoroscopic block's duration carefully. Hear it as one plausible course, not a figure to plan around. A second block did roughly the same. No published evidence tells me a third would. What changed was the ratio. Fewer emergency visits, a lower dose, weight regained. That is not a cure. The disease is still there. What was bought was function, and enough quiet for the slow work no needle will do. If your pain has outlasted the inflammation that started it, you are not imagining it. If you have been told that escalating opioids are all that remains, that is not a diagnosis. It is the absence of one. A celiac plexus block is a targeted, time-limited interruption of one pathway. It belongs in a sequence. I will tell you honestly when you are a candidate and when you are not. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.